Well, thank you for joining us today. Give a little introduction. As she says, I'm the Global Biomedical Informatics Lead. I'm a gynecological oncologist by clinical training. My PhD is in neuroendocrinology, and despite that, I sit in technology within Accenture because I also have a master's in computer science, so I build our platforms. This is my latest platform that I've built and ported to AWS. And I want to talk to you a little bit about what you can learn from these platforms and what it does. So I'll tell you, first of all, a little bit about what the platform is and what its function is. And then I'm going to go through some use cases that will let you know what you can do with data and, frankly, what you can do with Fire. And then I'm going to talk to you about why AWS has a built for analytics, built for big data platform as a cloud provider, and why you should think about that. So first I'm going to kind of talk a little bit about our tools and how we access that, go over a little bit about the platform itself. So we have 55 million patients on our platform with longitudinal data up to, in some cases, 15 years. It is data that is derived out of electronic medical record systems, both inpatient and ambulatory, so a broad spectrum of conditions that you will see. We have taken that data, and because there is a known genetic link to many different conditions, we've taken all the knowledge about genetic relationships between diseases and applied that to those conditions within the platform. So now you can see for any condition, whether it has a genetic link or not. If it has a genetic link, what are the variants associated with that? Which variants are specific to that condition? What other conditions do those variants also cross over? And then what are the proteins produced by the genes? What is its function at the cell? What biopathways do they work in? What is the DNA driving that? So all down to that side of it. Now, you can think about that as, oh, that's only pertinent to research. But I'm going to tell you it's not just research, right? And I'll tell you why and some of the other things we've built around that. So when you look at the process of how do you build a platform like that, and what do you have to do to make it functional and provide the analytics that are going to give you the insights out of it? Because at the end of the day, it really is all about the analytics. It's not so much about the data. It's certainly you have to do a lot to the data, and you have to have the data, and you have to have a lot of data. But at the end of the day, it's to get that analytic insight to really change healthcare and to take a position where you're not going to rest on what's known today, but you're going to derive new things that are not known today. And I'll talk a little bit about some of the things we've done on the platform in that realm. So obviously, you need the data, but then you are going to have to take that data and you're going to have to standardize it, right? Because if you have data out of 150 different hospital systems and EMR systems of different flavors and different ways to put the data in, and some of it coded in one language, some of it coded in another terminology system, you've got to standardize that information and make it look the same so that you can query it, right? In our case, with all of that data, it's an ongoing process. When you're bringing data in, you have to have a pipeline that you can do the ETL processing of it. Most of it we do in memory to be able to bind the terminology services to it. If you want to know the details of that a little bit, we use the Athena terminology services out of OHDSI, the OMOP teams to do that, because there's a lot of the crosswalks, and because it also lets us add into that all the genetic terminologies that we need to do that, because there are a bunch of those as well, and you have to standardize those, decide what you're going to tag a protein with, what you're going to tag a gene with, what you're going to tag a biopathway with. Once you've done all of that, you've got to be able to provide some access to it, right? And so that is what our cohort browser does, and I'll show you a little bit about that in a minute. And then the real game changer is the analytics you do on top of it. So we have, this show is all about Gen AI, but there are lots of analytics that you can do and lots of things that add to it that help with that. And some of the use cases I will talk to you about are Gen AI, but others are the advanced graph analytics you can do on this. And that really gives a ton of insights. So I'm going to go through a little bit about some of the use cases that we've done over the last couple of years to show you an idea about how you can change healthcare and how you can have novel discoveries if you have enough data, and that specifically with that genetic overlay that helps with that. So one of the things that we do in that is really, I think about the platform when you have that genetic overlay, it's really about hypothesis generation, right? Because we're not actually treating a patient, it's hard to prove those. So we can't say for sure that the hypotheses that we generate on the platform with data are actually going to flow through to real findings. So you have to partner with the healthcare system. And so when we are doing these kinds of things, and we have a particular focus on something, a particular disease, and from my perspective, I'm not worried about high blood pressure or some of the chronic diseases. I'm trying to solve the really hard things, right? So for COVID, when it came out, we didn't know a whole lot about that. We didn't know exactly what was killing people. We didn't know who was getting it, all of those things. Now we know there are 11 genetic mutations that drive whether you are going to be, one, whether you're going to get COVID, and two, whether you're going to be really sick with it or you're not going to be very sick with it. And I'll give you an example. There are 11 known mutations. If you're carrying 8 or more of those, your chances of being hospitalized is pretty high. You're not carrying any of them, or you're carrying 1 or 2. I carry 1 of them. I've had COVID twice. Neither time did I even know I had it, right? So I had no symptoms whatsoever. First time picked up on an antibody screen. Next time, this was last summer, I was in Finland, in Helsinki, having dinner with a couple of friends, went from there to the Netherlands to see some of my clients, then went to Dublin with my AI team, sitting there. My second day there, I get a text saying, "How are you feeling?" I said, "Feel great." And these are the guys I went to dinner with. They said, "Well, we're pretty sick with COVID." I said, "I do not have COVID." They said, "Maybe you should test." So walk up front, get a COVID test. I was positive, right? But I had no idea, right? So at any rate, that's all about genetics, right? It's who's going to get it or not going to get it. We also do a lot of predictive analytics. So we drive all of Accenture's algorithms in the healthcare area off of those 55 million patients, because now we can do good diabetic algorithms. We can tell you what the chance of you having a major complication when you're there. Sepsis algorithms. We have 49,000 patients who've had severe sepsis. We can build algorithms that don't only do what most sepsis algorithms are really saying, once I've got you in the hospital, I know that if you start to run a fever and you drop your blood pressure and your O2 saturation drops, you're probably going into early sepsis. I need to keep you from going to severe sepsis and dying, right? So that's what most algorithms do. If you're really sophisticated, you might be looking at monocyte distribution width that doesn't come off your Coulter count. You have a special instrument to look at that, right? But that's the most sophisticated that you get. You already have to be in the hospital. You all have to be somebody that you're looking for. With Gen AI and with all the data we have built a sepsis algorithm that looks at all of the data that you had 10 years before and look at the specific conditions, some of them making you more likely. So now we can predict with about a 97% accuracy if you are going to get sepsis when you hit the front door of the hospital, not once you're inside. So pretty amazing things you can do with this much data. And of course, because we have a lot of work, I lead our research side, both in academic medicine and in what we do in life sciences. We have examples of drug discovery, not of known proteins that bind to a receptor, but novel proteins that we have identified because we have tools that walk across the graph analytics and say, this isn't known to science, but it's likely something that has k-nearest neighbors that tells us it's close to these other things. You should look at this protein. And one of the ones we identified that for a pharma, we're publishing this paper next week, basically said the pharma client gave us these proteins they thought would bind to a receptor in the brain that would treat migraine. And they said, can you show me some others? It actually wasn't one of the ones they knew and they had researched and said these are likely to bind. It was one we identified by our graph analytics and our suggested proteins that may be related. It was one of those that was the best binding. And now that's a drug coming out to market. So these are the things that you can do on this data. Now, the other things you can do, we've just built on a Smart on Fire application that runs in the EMR that isn't anything about drug discovery or novel identification of things like we did for COVID-19, where we told the NIH, you're wrong. It's not the extrinsic clotting pathway. We have the data to show that it's the complement clotting cascade that is causing this DVT and PE. It wasn't what our deep scientific researchers at the NIH said, it was what we found in our data that changed that and said, don't heparinize them, treat them with steroids. That's going to stop that part of it. And we did that with data. Fortunately, somebody watched the presentation that I did at the University of Buffalo from Scripps, sent me an email an hour later. Of course, they said, have you published that yet? I said, no, we haven't published it yet because it's a hypothesis. He goes, oh, we have the T cells, the B cells in the patients. You are right. I don't know how you did it with just data, but you're right. Let's co-publish this. So we did a HIMSS presentation year before last on what we did and what Scripps did. And now that's a drug that is actually coming out pretty soon on treating that kind of DVT and PE in COVID. So those are the things that you find. Now, this is a little bit about that. I just kind of covered that, so I'm not going to go through this, but it was all about rank ordering the genes, which is how we did this. We used our tools in graph analytics. And by the way, one of those tools we've open sourced. You can go up to the Accenture GitHub and pull down that graph analytic tool and load your data in it. It's not quite as sophisticated as the one we use every day, but it's definitely gets everybody a start into graph analytics. So what we did, we had just won, Accenture had just won the Kaggle competition on text analytics for everything in the literature around COVID-19. So we had already processed COVID-19, SARS, MERS, all of those. And then we did all the genes related to deep vein thrombosis and pulmonary embolism. We took that, put it in the graph, rank ordered the genes, 24,000 of them, spit out the top 20. 5 of those mapped to the complement clotting cascade, only 1 to the extrinsic clotting pathway. And that's how we said, this is probably the pathway. That's how we reached that. Now, if we think about that and what you have to do to reach those kinds of analytics and how you manage that much data and how you make it multi-use, like the Smart on Fire application we've just finished building in the healthcare system, that isn't about solving scientific problems, it's about improving healthcare. So the Smart on Fire application uses a CDS hook that fires when you open the medical record in Cerner or Epic or other fire compliant systems. One of the triggers that you can use is writing a medication or opening a record. So when you open the record, we pull the reason that the person is coming into the healthcare system for care, and then we pass it to the platform and we send back in a CDS card the top 5 genetically related diseases that you should pay attention to. So if I'm seeing a patient for getting severe major depression, we're going to send something back to the psychiatrist to tell them probably something they're not thinking about. but they're going to see this patient pretty soon in the emergency room because they're 9 times as likely to have migraine headaches because of the genetics. They are 5 times as likely to have Parkinson's disease if they have severe major depression. They are 12 times as likely to abuse alcohol and 14 times as likely to abuse anxiolytic drugs, right? And so, you know, a lot of times people thought, oh, they're depressed, so they drink. No, they drink and they're depressed because they have the genetic programming to do that. It has nothing to do with, you know, a substance abuse problem. It has to do with the genetics they have. And you would probably find that with a lot of people on the street as well for that. So that's how you use it in healthcare. If I had a lupus patient that came in and it fired that, we would tell them you're 10 times as likely to have B-cell lymphoma. You are 7.5 times as likely to have breast cancer. So if you know that, I'm going to order a mammogram early on for that patient when they're 42, not when the government says at 50 I order mammogram, because now I'm going to have that patient when they're DCIS and can just do a lumpectomy and don't need chemotherapy or radiation therapy instead of seeing them 8 years later when they have stage 2B breast cancer. And now I got to hit them with chemo and hit them with radiation therapy and hope that they meet that 60% 5-year survival rate, right? So total game changer for that if you know to look early on. So why AWS and what can you do there? So one of the really cool things about AWS and their health data lake, it is a fully FHIR compliant backend. I don't think any of the other MAGs have that, right? So now I can store every bit of my data in FHIR models, which means if you read a paper, and this was actually published by Google and UCSF and Carnegie Mellon about 4 or 5 years ago, and what they did, they looked at the difference of being of the analytic uplift you do on predictive models if you're doing it off of FHIR model versus if you're doing it off of flat tables in SAS, right? And you had a 7% uplift in your predictive model off of FHIR. Now, why? Because you have all the contextual relationships of your data to each other. So you get much more analytic power because you're not doing it pieces of data at a time. You're doing it off the context that you have, and that gives you a richer analytic view of it. So number one, we get better analytics off the FHIR model. Number two, you want to build a smart on FHIR application? You already have everything in FHIR. You can already do that, right? And you can do that straight off the data lake. So it gives you that. The other thing, so you want to use OMOP. You can do OMOP to FHIR and FHIR to OMOP, and you can do that in AWS. They have both of the tools there. So if I want a simpler model, I can do it in OMOP. If I need all the richness of FHIR, which will handle everything in claims, everything in healthcare, most of genomics, and when I'm on the genomics, or I'm on the FHIR advisory board in HLS, I've been writing the standard for 25 years. So now I'm working on getting all the stuff I want on the research side also into FHIR, from biopathways, proteomics, transcriptomics in there. So we will fully have everything there pretty soon that you want to do even in the genetics world. And that is what you can do off of AWS. And we have a one push button on our cohort browser that will segment the data for you. You don't have to write any SQL. It will do very complex things. It'll say, okay, I want this sex, I want patients alive or dead, I want race and ethnicity, I want to build a cohort by a gene, build a cohort by a variant. So it'll give me all diseases related to that particular variant, all diseases related to that gene. It will also do the standard things by conditions, medications. So I can say, I want a patient on, with this condition, not with this condition, on this medication, or one of these 3 medications. Oh, and by the way, for these 2 conditions I want them to have, I want this condition to occur before that condition by at least 2 years. And I want the patient to be at least this old when they got that first condition, right? There's no SQL to write. It does all that SQL in the back end, builds that cohort. And then when the cohort is built, there's one push button to push it in all the deep analytics that you see on AWS. that I can push it to a data notebook. I can push it to flat tables if I want to put it in SAS or some other tool. I can push it to a graph with one button. So the data scientist also has no work to do to wrangle his standardized data. It's straight into your analytic group. So that's the power of AWS.